There's one question from Mark.
I just want to ask the second speaker. As I see, you fixed the coracoid with only one point of fixation with two buttons.
Yes.
Yeah, and so I want to ask the third speaker. He fixed the coracoid with the Di Giacomo plate. Okay. Why you use this kind of fixation and why you use this kind of fixation? There is a difference in the healing. There is a biomechanical reason because you choose the Di Giacomo way of fixation, or to the second speaker, is a biomechanical or biological reason because you choose only two buttons. First, and
maybe
just
maybe
1 second.
you
can start.
Dr. Rosser starts first.
Just
yeah.
1 second. Do you think that using only two buttons, like Pasquale Bolo says, you can have a twisting of the coracoid, or there is no problem because when you fix it, the compression force avoid the twisting of the coracoid?
This question was a question they ask us very often, and we made another study, 2 versus 4 buttons, and we are publishing it now, and we presented to the SFA last year, and we have assessed that when we use 4 versus 2, the only difference between both techniques were longer time where you use 4 buttons, most problem with sutures management, and no effect on veiling. The first is more a surgery which lasts longer. The second one was problem with suture management.
Yes.
But in the end, we have the same rate of bone block healing, and no difference on positioning of the graft. Personally, I prefer to have only one button because, as I showed this morning, I think that when you have a little bit of overhang, the traction of a tangent condon allows a little bit of rotation after 2 weeks and permit to correct this overhang. So personally, I will not move from 2 to 4 buttons, as I have made some with Pascal Boileau when I was in Nice Hospital, and I can say that 2 buttons is enough, 2 buttons heal well, and 4 buttons is for me a shame and a loss of time.
Okay. To Dr.
Bruno?
Tissot?
Do you want to answer?
Yes, I find very pleasant the design of the Di Giacomo plate because you create more pressure medially than laterally. It's the first reason I use it, and the second reason is you move the forces everywhere onto the coracoid process, and you protect the screw head, because before I used without the Di Giacomo plate, and I have some coracoid process fracture with the screw head, and I prefer use Di Giacomo plate. I mean, you protect little bit the coracoid process from fractures, and I mean it's very interesting to use it. Ettore.
Yeah, I have a question regarding 2 buttons per buttons. I agree that probably the final results on CT scan can be equal. Although a study we have done comparing 4 buttons and 2 screws shows that 2 buttons is better than 2 screws. So I think we need further study for looking at that. Second thing is that with only 2 buttons, you can achieve some kind of rotational stability only if you press on top the labrum and the ligaments. but it's not the same than having 4 buttons. And regarding to be easier or more difficult, we developed a different technique with different steps, but having the possibility of pulling and releasing 4 buttons makes the passage of the coracoid through the subscap split easier and saving you a lot of time. So changing the steps, we don't do the same steps. We drill the tunnel first, and then we put the button first, and then we cut the coracoid. We don't need all the spreader or anything to put inside. So I think it's a surgeon preference, but if you do things differently, in my opinion, it's easier with 4 buttons than 2. The final result is, if it's good both ways, of course it's a surgeon preference, but I wouldn't say that it's easier or difficult, depends the way you do the different steps.
You want a quick answer to that?
Yeah.
Yeah.
I think that the problem is not 2 or 4 buttons. I think that it's the choice of techniques. For the Latarjet, I think 2 buttons are enough, but for the techniques you show us yesterday in the live surgery and today, I agree with you. I think that 4 buttons are needed because you don't have a the conjunct tendon, sorry, and it allows you to put pressure and to orient and to place the bone block in the right position. So as you use it and you pass the bone block in a different way, I think that for your techniques, effectively the 4 buttons are a good option, and I think the best option. But I think that the choice you made for your technique, which is the right choice for you, isn't the right choice for the Latarjet technique arthroscopically with the buttons.
I reply once more if I can.
Yes.
Because I agree that for bone block it's strictly necessary to have 4 buttons. But what I'm saying is that if you do different things, to have 4 points for introducing the coracoid, in my opinion, it's easier. So maybe it's not strictly needed, but I think that also for the coracoid with the conjoint tendon, makes easier the passage through the split. Of course, we can do things in different ways. At the end is the results. If you have a good CT scan view in both ways, it depends on you. But I won't say it's better for me. I won't say it's worse, it's more complicated, because maybe it's more complicated for you or for Pascal, but it's just a different approach.
Thank you.
I
Thank you. I have a question for all the 3 speakers. That's me included. What is the main advantage with doing it your way, and what is the main disadvantage? 1 point. What is the main advantage, and what is the main disadvantage with your procedure? I'll start first.
The main advantage for me is faster recovery in my personal series.
This was a technical question,
Ah,
not the result of for the patient. This was a pure technical question. We all know that these procedures work.
So for me, the advantages of this technique is that we do arthroscopy, and when we do arthroscopy, we have to be not fixed, and the buttons allows you some kind of mobility, and I think it's easier to fix a button than a screw. So for me, it's an advantage because when you are tight in arthroscopy, it's more difficult. So
only one.
Only one. And the bad things for the procedure is that I think it's quite demanding and have a long learning curve. But when you have learned, it's okay.
Bruno.
The main advantage is, I am sure my tunnel for a screw is very parallel to the glenoid surface, and the positioning of the coracoid process is definitively easier to do like this. It's the first advantage. The disadvantage is regarding the previous technique I use. I don't see a lot of disadvantage at the moment because I need to improve my technique. But the disadvantage is when I pass the coacoid process through the subscapulary split, it's more demanding because it's in my end it's relatively difficult to elevate the upper part of the subscap in the right position in very medially, but is only the disadvantage of this technique.
And then me. I think the main advantage with doing arthroscopic l'attaché, and I don't think it is dependent on the technique, although I think we do a little bit more of dissection and visualization than the two others of you. The main advantage for me is that I have found a new room to play in, and that is very, very, very convenient, for example, for visualization of the subscap if you want to do a complex subscap repair. You can work outside the box, and that is very, very unexpected, actually, advantage of the procedure. The disadvantage for me is that it's very, very not steep, very slow learning curve. It's a difficult procedure, and it's a risky procedure. So you have to be very meticulous when you start out doing this. And as I said, if you can see what you do, it's safe. If you cannot see what you are doing, you should not do it. You have to find something else to do. So that is my main disadvantage. Any more questions from? Yes, there is a question. Yeah.
Yes. Coming back to your own nice remarks, I would like to ask you, to all of you, of course, what is the high risk ratio regarding to the suprascapular nerve, especially just after down the spinoglenoid nodes, because I think, especially with the posterior tunnel placement, maybe that increases the risk of traumatizing this nerve.
I think that's a very relevant and good question. I will first answer it in accordance with my technique. If I put my drill holes and my screws in the right direction, I will not jeopardize the suprascapular nerve because I will be lateral to the suprascapular nerve. So I think if I had very, very protruding screws, I didn't measure the length of the screws properly, and they were protruding out in the back, there is a possible risk. But still, if the screws are in the correct position, parallel to the joint line, they should be out of the way. So, but the risk is that you have, like very frequently in the open procedure, you have screws that are angulated medially because it's so difficult to open in a big guy to have them parallel to the joint line. So that's for the screw technique. You can compress. You can also
Yes.
remove the screws.
With the posterior guide, you reduce the risk as much as possible because you are very lateral with the exit of the screw posteriorly, and it's definitively safe. You cannot damage the suprascapular nerve in the spinoglenoid notch. I mean, it's the same with endobuton because the guide protects the nerve as well. I have one question to Michel, for you, Michel. What do you do when the anterior capsule is totally disappeared?
I have this case one time, and I just do the l'attaché, and I don't make it extra-articular. But very often when you have a capsule which is very distended, you can, even with with the spectrum, you can attach some soft tissues, and I think that when you can do it, you have to do it for the proprioception. And at that time, even if I have bad soft tissues in the anterior part of the joint, I always find something to reattach.
In my opinion, there is different indication for instability treatment. And I mean, if you have a good capsule, it's not necessary to make a Latarjet procedure, because Latarjet procedure is definitively for capsule insufficiency. And I mean the technique described by Eden Binet in first and make arthroscopically by Ettore and Marcus Schebel is the best way for the bone defect with a good capsule. It's not necessary to make a sling effect more. And if you restore the bone block, you remake the capsule in the right position, you can have certainly a good result, and you can take any risk regarding the subscapularis muscle, because Latarjet procedure damage definitively the subscapularis muscle, and you probably reduce the risk of osteoarthritis, because after 20 years we can see a lot of arthritis after Latarjet procedure. It's typically a French procedure. Everybody, some people very famous use the Latarjet procedure for painful instability, and is not the best way, I think. Not for me.
No, I agree with you. But I think when you have, most of the time you have anterior labrum capsule, but sometimes it's just healed medially. And with young people with who has quite good capsule or labrum, but he healed medially, you always find something to reattach. After that, if you, for me, it's quite rare to find a bone defect and nothing to reattach after to put the bone block extra-articular. But you're right. I think that the technique of Ettore is good for these cases when you have a good capsule and just bone defect.
And if there are,
You will.
I'm about to close the session.
Just one
but-
another question. Yes,
please.
another
Yeah.
question to Michel. If you have a very big bone defect, you increase the piece of coracoid process, and what do you manage it? Because with a regular Latarjet, with the 2 screws, we grasp a lot of bone block to restore the bone stock. With Pascal Boileau technique, the piece of bone is less, and probably for big defect is not big enough.
At that time, the only time I have this case, I asked Mr. Boileau what to do first.
It's a good idea.
And then we decided together to do an Eden Binet in this case, to have a biggest piece of bone, and then to retouch in front of the Eden Binet the soft tissue we have. But I think that for that cases, maybe it's the limit of the Latarjet procedure as I do it.
We close.
Any further questions, or are you as hungry and thirsty as I am? It's been a long day. The Greek programs are very, very busy. It's scheduled with no breaks and a lot of intensity. So thank you for staying with us until the far end, and hope to see you tomorrow.